this season, but we will resume again in September of the fall of 2025. It's been great. This is my very first year of helping with the bucket courses. Will you help me with giving a big round of applause to, and I'll have you stand up, to those who are here who are on the bucket course committee. I didn't tell them I would ask. Do you guys mind standing up? Let's give them a round of applause. They work so hard each and every day, or each and every week, I should say. Thank you, everyone, each and every week to help set up, take down, keep me organized and in line and everything moving. I really, really appreciate everything. So my name is Sarah Smith. I work at Grinnell College in the Office of Community Partnerships, Planning, and Research, and I have the honor of partnering with the Bucket Course Committee to bring these classes to you all each and every week. As we move into the next year, one thing I want to point out real quick is I would love your feedback as to who you would like at these courses. It was really great to have a lot of responses this year, and Unity Point Health was one of them. So excited to finish with you guys and having more individuals here from the hospital talking as well. A couple reminders before I introduce our speaker. Please make sure that you turn your T-coils on if you have those. Silence your phones. I'll try to remember to tell you to turn it back on, but probably someone in the committee will remind me because I will forget. If you can afterwards stay and put the chairs away, that would be wonderful. And as far as questions go, today we're going to kind of feel it out. We'll see how things go. We may do it in each section of topics, or we may save it to the end. And so we'll just let you know. But I'll come around with the microphone so everyone can hear your question at that time. So now let's move into the good stuff. So today we have Dr. Tedesco with us from Unity Point Health and DeMoss Orthopedic. Is it? Yeah, DeMoss Orthopedics. From out of Des Moines. But really excited to have Dr. Tedesco with us today. Talk about, get you back to what you love, which is a good thing, being active and feeling good. So without further ado, will you please help me welcome Dr. Tedesco.
Thank you, everyone. Can everyone hear me okay? Good? All right. So I know a lot of you already from my clinical experience, but those of you that don't know me, I figured we'd start just kind of with a general overview. I mean, not everyone knows exactly what an orthopedic surgeon is, kind of what my purview of practice is. So we'll start there, kind of a broad overview. So in general, orthopedics is a medical specialty focused on the joints and the musculoskeletal system. So bones, tendons, ligaments, nerves, even all that stuff that, is what kind of gets us moving. And so my job is to help promote quality of life by helping patients stay active. And so a lot of you that have come to see me in the office, you probably have heard me say, you got to stay active, got to keep things moving. And so that's kind of the whole goal of this talk. I was somewhat warned ahead of time about the patient population for this talk, so I figured I'd geared it a little bit towards the older population. And so the joke all through residency and even now into my practice is that the general surgeons always give us heck because they're the ones that are coming in the middle of the night, somebody that perforated their bowel, they're really sick, they're life or death situation, they're the ones fixing those. We don't really do that in orthopedics. The one thing that we do though is we do help save livelihoods and quality of life. So very little in orthopedics is life or death. A lot of what I deal with is basically painful, something that's limiting your quality of life. And so my job is to ultimately get you back to doing those things. And so the orthopedic surgery and orthopedic surgeon as myself is a little bit of a misnomer. As a lot of you guys know from coming to see me, surgery is and should be a last resort here. And so a lot of times, what your visit with me may not even get to the surgery part. Sometimes there's ways to get you feeling better, get you back to doing that stuff without going down that road. So my purview of practice, in general, I am a general orthopedic surgeon. My fellowship was in sports medicine. And so, a little bit of everything is what I do here. Being the only orthopedic surgeon here full time, I try to take care of a little bit of everything. And so I do a fair number of joint replacements. Now, knee and shoulder are really all that I will do. Anyone that's come to me for a hip, they know I usually send you to one of my partners in Des Moines for stuff like that. But I deal with a lot of fractures. We deal, with all sorts of injections. We do minor hand stuff, carpal tunnels, trigger fingers. So we deal with a lot of stuff here. And I always do tell people, I mean, even if it's something that I don't do personally, I'm a good place to start. I can see, kind of get you into the right hands. What's nice is me being a member of DMOS, I have all sorts of partners, that are less than an hour away to get you to maybe to the right person here. So the sports medicine is a little bit more focused on arthroscopic procedures, the knee, the shoulder. My fellowship in particular was really focused a lot on the shoulder. And so, a lot of my favorite things to do are about the shoulder. And so a little bit about me and my background. A lot of you guys know this about me already, but so one of the things I get a little bit of heck on is the sports teams that I like. People always sometimes wonder, it's a very random assortment of teams. So I'm a big Pittsburgh Steelers fan and a big fan of the Tampa Bay Rays, which how do you come across those two? So I grew up in Erie, Pennsylvania. I lived there till I was about 10, and then when I was 10, then I moved to Florida, spent most of my life then in Florida, went to high school, undergrad, medical school, all in Florida, and so that's where the Tampa Bay Rays came from. And then my fellowship was out in San Diego, where we worked with the San Diego State University, so I've become a Aztec fan there. And then I'm a very lucky man, married to a beautiful wife. I have 2 healthy boys, and then we have 2 Pomeranians. And somebody once told me that what's the point of having Pomeranians if you can't dress them up? All right, so let's get into a little bit about what coming to see me looks like. So your visit with me, as a general broad overview, you're going to start with, first of all, a history and physical exam, and basically what does that mean? So that's basically where we sit and we talk, and I see what's hurting you, how long has it been hurting you, what are your expectations, what's the stuff you want to do, because a lot of times, even before I see your imaging, even before I know kind of exactly what's going on, I already have an idea of where we're heading just by hearing what you're talking about, hearing your expectations for things. So a lot of you guys know that I spend a good time, talking to you, kind of hearing where we're at and how much this current issue is affecting our quality of life. And so a lot of times, that goes hand in hand with, we do a lot of imaging in orthopedics. So almost most people that are coming to see me for the first time, if they've not had an x-ray of that joint, I usually start there. And sometimes people are a little upset about that, where it's like, wow, it's my arm that hurts. It doesn't hurt in the shoulder. But there are bad things that can be hanging out in there that can be causing some of this. So an x-ray is a really nice screening tool. It helps us to evaluate if there's arthritis in these certain areas, certainly rules out the very bad things. So a lot of times, that's where we'll start. Now, a lot of you guys, I'm sure, are very familiar dealing with insurances and the lovely, aspect of that. And so not always do we jump right into the further advanced imaging, because sometimes there are different hoops we have to jump through there. There's all sorts of special tests that sometimes we order, with an EMG, which is what they're picturing down here. That's a special test for some nerves. I've been told that's not the most fun test. I've never had it done myself, but anyone that's had it done, I'm sorry if I've ordered that for you. And then sometimes some lab work, some other things like that. Again, this is kind of a basic overview about what all we will do. And then, the treatment, one of the things I tell my patients a lot of times, I'm the dumb bone doctor. There are 5 things I can do to people. And so this is basically it. So I can put you on a pill. So most often what I use are anti-inflammatories. Now the downside of that is, as we get older, anti-inflammatories are rough on our stomach, our kidneys. They are not the safest medicines. And a lot of times we think of them as vitamins. You can get an ibuprofen over the counter. There are a lot of side effects that potentially we may not be aware of. And so, some of those stuff I use very sparingly. Some of you may have experience with this, where I'm really flared up, I'm really uncomfortable, but I've got my kid's getting married this weekend, where usually that go-to in that stage is to put you on a short course of steroids. Steroids have all sorts of side effects long-term, but sometimes they're a good solution short-term to get you some relief. And so sometimes, I'll do that for some people before a vacation, stuff like that. Then we have muscle relaxers. Then, of course, the big one that no one loves is opioids. Now, they make those for a reason. I do very painful things to people, and a lot of those require quite a good bit of pain management. And so usually that's when we start getting into those things for fractures, after surgery, that type of stuff. I do a lot of injections. So that's number 2 on things I could do. I can put you on a pill. I can give you an injection. Injections for most things are Band-Aids by all means. It's there to help your pain, help with inflammation, make you feel a little bit better. But a lot of the same things that we're dealing with, they're not cures. But at the same time, when the cure is a very difficult thing to undergo, if it's me, while the Band-Aids are holding water, I would put a Band-Aid on it until it's not working anymore. So I do a lot of those in the office. They sound very scary. I very rarely get feedback, especially in the knees and shoulders, which is mostly what we're talking about today, that they're really uncomfortable. So most of the time, most of you guys know I have this cold spray that helps freeze your skin. Usually don't feel the needle so much, and so they're not the end of the world. I have a lot of people that come see me every 3 months, get their shots, and then makes life a lot more livable. So on to number 3, casting, bracing, some kind of immobilization. Now, sometimes, a knee brace or for a painful knee, some things, especially as we get older, our joints are trying to stiffen up on us. And so sometimes the bracing can be somewhat counterintuitive because it's stopping more motion where it's like, we want these things to move. So I use those braces, especially, for knee arthritis, stuff like that, sparingly, but there are some options there. Then number 4 is we can put you in rehab. PT is, I think a lot of people don't understand the main goals of physical therapy, but the first thing the physical therapists do when anyone goes to PT is they help address swelling and inflammation in these areas, where a lot of times I put people in PT and they're like, well, I exercise on my own. It's like, well, there are different things that they do in PT. And so PT is a very special role in orthopedics. Very little of what I do is beneficial to people without good physical therapy. So physical therapy is very important. And then ultimately, number 5 is the big one, which, if all this other stuff failed, then that's when we talk about surgery. And so, like I said, it should be a last resort, or, if something is just an unacceptable, we can't let this heal, it's going to give you a bad outcome, that's when we also will talk about surgery. And so most of you know me that have seen me. I'm a super conservative surgeon. If there's ways we can manage things without surgery, that's usually what I recommend, and that's usually what we do. So now, one of the things that I love most, and a lot of you that have seen me in the office will know this, and part of the reason why I jumped on this, education of patients is something that I love to do. I feel that so many times when you're asking a patient to do something, if they don't understand why you're asking them to do it, if they don't understand the rationale behind that, they're not going to do it. And so I spend a lot of times kind of going over with people like, this is why we're doing this. This is why why we need to do this way. And I think that stuff is very helpful. It goes a long way at, helping the patients understand why they're doing the things we're asking of them. And then, there are other things that sometimes people aren't aware of that can be affecting their joint and bone health, one of which is smoking. Now, fortunately, I feel like as, we've gotten into the 2010s, 2020s, I see a lot less smoking. But one of the things about smoking, clearly I care about your lungs and overall health, but for an orthopedic surgeon, the lungs aren't the problem with smoking, it's the nicotine. The nicotine is a vasoconstrictor. It decreases the blood flow to our bones. So somebody after a big surgery, a broken bone, stuff like that, if you're using nicotine, it slows down that healing. And so, again, sometimes going over that with people is important and can be eye-opening to them. But also, here in Iowa, we deal with a fair amount of obesity. And the one thing I talk to my patients about, with knees especially, this can be a huge problem. Our joints do not grow with our soft tissue. And as we put on weight, our knees see 4 times our body weight. 4 times our body weight. And so somebody that puts on 10 pounds, that's 40 extra pounds your knees are seeing. And so, again, a lot of times that can be very eye-opening to people where it's like, oh, my gosh, wow. And so, the other thing is all of these things that can be modified, diet, exercise, all that stuff. And then, again, we spend a lot of time talking about what all this disease entails, what this is going to look like going forward, what we can expect from a surgery, all that stuff. And so, activities to encourage and avoid, as most of you know, like we already talked about, I like people to keep moving. I rarely take activities away from my older patients because I would much rather you be moving, staying active than being sedentary, because then things stiffen up quite a bit that way. All right. So as far as the general overview, that's about, kind of the general overview of what I deal with. So I figured, with limited time, I would focus my talk on the 2 things I see and do the most, which are the knee and the shoulder. So we'll talk about we'll talk about the knee and the shoulder overview in general, and then a couple common problems that I see, especially in this age population, and kind of how we manage them. Just so again, everyone can kind of understand a little bit about the rationale of what we do in the office. So we'll talk about the basic anatomy of the knee first. So the knee is a pretty complex joint. We think of the knee as a hinge joint, but it really is a very complex hinge joint. It rotates. It also has some motion in these planes. And there are also really two different joints that make up our knee joint. So not only do we have the articulation between the thigh bone, your femur, and the tibia, but also then your kneecap here articulates with the femur. And so I have some people where this joint looks great, but this one is a mess, and they have a lot of pain with that. And so, again, there's a lot that's going on with the knee. Any of our joints, there are different things that provide stability to that joint. And now each of our joints, we have these static stabilizers, which basically means that they don't move. They're not moving with our muscles, things like that. And so with our knees, we have all sorts of different ligaments that provide stability to the joint, the ACL, PCL, MCL, LCL. That's a lot of information for another day, but that's ultimately what helps provide stability to this knee. And then we also have these dynamic stabilizers. Dynamic meaning that things that move, things that we can kind of train to do different things. And so your quadriceps, your hamstrings also help to provide secondary stability. Then your knee, and one of the things I highlighted here, one of the most important things are these shock absorbers in our knee. And so the two main ones are the articular cartilage, which is this cartilage on the ends of the bones here, nice smooth cartilage, and then our meniscus, which we'll kind of go over in detail about exactly what that is. And then our knee joint lining, which is called the synovial membrane, this is what helps kind of release fluid into our knee joint, helps lubricate that knee joint, which, and sometimes some different pathologies is part of the problem here. So let's talk a little more about that articular cartilage, because this is kind of the holy grail in orthopedics. So it's a smooth, slippery hyaline cartilage, which is a special kind of cartilage. A lot of the cartilage that occurs laterally in the body is either fibrocartilage, elastic cartilage. This hyaline cartilage is exclusive to our articular cartilage. And like I said, this is kind of the holy grail in orthopedics. When this goes, we have tried all sorts of different things throughout the years to get that cartilage to regrow. It doesn't work reliably. We can sometimes get some fibrocartilage to grow, other stuff to grow, but it doesn't work nearly as well, and it's not as predictable, which is why the cure for a knee that looks like this is still metal and plastic, because this cartilage, again, we can't really get it to regrow. Once it's lost, then it's a big, big problem. And that's ultimately the primary problem in arthritis, osteoarthritis in particular. So there's a little cartoon here, if this will work. We'll see if this will play for us. So this kind of just goes over the little bit of the articular cartilage.
Walk, run, jump, kick, or climb. Ligaments, tendons, and muscles give the knee stability and hold it together. Rubbery tissue called cartilage covers and cushions the ends of the bones that make up the knee. These bones include the femur or thigh bone, the tibia or shin bone, and the patella or kneecap. Osteoarthritis of the knee means the cartilage in the joint has broken down because of excessive wear due to obesity, injuries, or overuse. It is also called degenerative arthritis and degenerative joint disease, or DJD. When knee cartilage is rough, frayed, or worn away, the bones can grind against each other, which can make the knee joint irritated, painful, and swollen.
So a lot of you have probably lived a lot of that, which is not the most pleasant feeling. All right, so now let's talk a little bit about some of the common pathology I see with the knee. Most common thing I see, probably even more so than arthritis, are these meniscus tears. So let's go into what the meniscus and what these are. So the meniscus, as I mentioned before, these little shock absorbers that sit in between the two bones of your knee, your thigh bone and your tibia. You have one on the inside, you have one on the outside. And from the top down, this is kind of what they look like here. They're C-shaped little shock absorbers here, which help to absorb shock in the knee. And typically, if a younger person, if I have a 20-year-old that has a meniscus tear, they had a big injury. They, twisted their knee, they felt a pop, it's all swollen, it's a mess. Usually they will know exactly when it happened. Someone that's older than 50, a lot of times they usually may not have an injury or something that's nearly as traumatic, where sometimes what I hear is like, I was just sitting down, I stood up and twisted my knee and it hurt, and then all of a sudden now it's really hurting. And so a lot of times if you hear that if someone, or you yourself have had surgery for torn cartilage in the knee, this is usually what they're talking about. If somebody's had a knee scope, this is usually what we're going after. What's unique about the meniscus is that only the outer 25% has blood supply. So a lot of times when we talk about a tear in the meniscus, so you have a tear or something like this, This outer portion here, only the small little bit of it has blood supply. So I can put stitches in this all day, but unless there's good blood supply to heal this, it doesn't work. So a lot of times when we talk about surgery for meniscus tears, we basically cut out the torn portion, because as these torn flaps of tissue get caught in between the gears here, that's where sometimes that sharp pain really comes from. And so again, a lot of times we're just kind of giving you smoother surfaces, which is part of the reason why I don't jump right into surgery here when it's like, well, we're not really fixing anything. We're just cutting out the torn stuff. If we can make this livable, then I think we try to do that before we jump to surgery. So a lot of times, again, especially in this patient population, a lot of times people may not attribute any recent injury where it's like, I don't know, all of a sudden it started hurting. Sometimes, again, it will be a twisting mechanism where I twisted my knee and, felt something, but may not always. But a lot of times these are the big things that I look for. Pain, obviously, but the catching and locking, because again, as that flap of tissue kind of moves around in there, if it gets caught in between the gears, a lot of times that will make the knee feel very unstable. And so a lot of times that will be people's complaints, is that I'll be fine, and then I'll twist the knee a certain way, and you get that real sharp pain, and a lot of times that's what this is from. And you kind of feel like the knee is unstable, like it's giving out, and then a lot of times just because it hurts, and people will start favoring their knee and limit their range of motion. So typically, again, if you've had me examine your knee for a meniscus tear, usually it's not very comfortable because I'm pressing around on the really painful spot. I crank on your knee and get it to hurt in that area just to kind of confirm that diagnosis. And so, there are different things that kind of help lead me into that. But a lot of times, this is back to what we were talking about before. I have a pretty good idea if somebody has a meniscus tear before we even look at all this imaging, just what they're telling me, where, again, it sounds like it. Their x-rays don't show much arthritis. This is probably what we're dealing with. So, again, with an x-ray, it's often negative. Now, again, sometimes, and this is a challenging situation that we'll get into, sometimes there is some arthritis in there, and that's a hard discussion with people where they come to you, they have arthritis in their knee never hurt until last week when they felt that pop in their knee. And it's a hard discussion to try and tell people. It's like, this has been brewing for a long time, even though you've only been hurting for the last week. And so sometimes those are a challenging thing to try to convince people that it's like, well, even though it's only been hurting you this last week, this has been happening for a while. And so sometimes that helps to dictate the way that we treat these. And so the MRI is the gold standard to see these. You can't see these on x-ray. MRI is really what shows them to us the best. And so when we look at this image down here, this is kind of what this looks like. So this is looking at the knee from the side. And so this is a normal meniscus here, and then on this side you can see a little tearing going right up through there. And so some people can't have an MRI, between pacemakers, other things like that. There are other options. There's a specific test where we can inject dye into your knee, get a CAT scan. So there are ways. You don't always have to have an MRI. MRI is what's best. All right. So treatment, and what do we do with these things? So again, my mainstay go-to is to manage these conservatively, not operatively, because a lot of people, I think, can get better without going down the road of surgery. And so a lot of times it's either PT, home exercises, get that knee moving again. But a lot of times when the knee's really acutely painful and swollen, that's hard to ask of people to do these exercises. And so usually that's when this stuff comes in, either an anti-inflammatory if you're able to, or if not, then usually an injection to help with the pain. Because a lot of times the therapists are going to ask you to do things that are going to hurt. And so unless we have something on board to help with that pain, it might be a challenge to kind of get through. And then like we talked about, bracing plus minus. Sometimes if somebody's really miserable, I'll try it, but rarely does that help a lot for these problems. And then, so again, the operative treatment is reserved for those that have tried all this stuff. They're not getting any better. It's still giving out on them. They can't trust this knee. And then also there are times where some of these tears, like some that look like this, where you have this big unstable flap of tissue, sometimes that can get caught and stuck in the knee, and somebody will come in and they can't move their knee at all. And so those are the ones that sometimes we get a little bit more aggressive too, where, again, they've got this big flap of tissue grinding, caught in the gears there, and it's just stuck. And so, those are the ones that sometimes, again, we will jump to surgery a little bit sooner. The other thing, too, younger patients that have a repairable tear, this meniscus, like we talked about, is a very important shock absorber in the knee. And so when we lose that, the articular cartilage, the other shock absorber in our knee, sees a lot more stress. And so to help protect that articular cartilage, we try to preserve that meniscus tissue. And so if it's a young person with a tear that's repairable, a lot of times I try to repair those sooner than later. But very rarely, like we talked about, are they actually repairable. So what does surgery for this look like? Now, more often than not, like I said, the main goal of surgery is to cut out the torn portion of the meniscus that's torn. And so we make little incisions on the knee kind of like this. I stick a camera inside your knee, which allows me to kind of see what I'm doing, and then we use these little small instruments to kind of trim that thing up there. And that's kind of what it looks like. And again, repair very rarely, but sometimes that's indicated. And so I think there's a little picture here, if this will work, about kind of what an inside of a knee through a scope looks like. So we'll see if this will work for us. Maybe not. That's okay. Well, so ultimately, I mean, again, this is what the inside of a knee looks like when I'm scoping. Here's the femur. This is the meniscus here. Now, you can't see it because he's got this instrument in here, but there's some fraying of this meniscus, and he's basically just smoothing it out. And again, that's ultimately what I'm doing, is giving you smoother surfaces for the most part. So what does this look like after the surgery? So if all we did was a partial meniscectomy, meaning that we basically cut out the torn portion, you don't really have much restrictions. I do tell people, of all the things I do to people, this is probably one of the easiest recoveries, where I don't mandate crutches. I let you put full weight on it. I let you walk on it. Usually it's a little sore and swollen for a little bit, but people bounce back pretty quickly. The one thing I always tell people, when NFL players have this done, now again, they're high peak performance athletes, but that's obviously a very physically demanding job they're getting back to. They're back on the field in 3 to 6 weeks. And so most people, within about a month to 6 weeks, they still have some swelling. Most people are feeling a lot better. They're not noticing that catching feeling in their knee, and they feel better. Now, again, if we repair, which again is very rarely going to happen, that's a big problem for people, because they cannot put any weight on it for 6 to 8 weeks. Again, the meniscus is an important shock absorber, so when we're bearing weight through it, we're putting a lot of stress through that repair. And so those people have to stay off this for 6 to 8 weeks. You need PT, these big clunky braces. It's a lot to put somebody through. And so rarely do I recommend that on somebody that's over the age of 30, 35, because again, we're not really buying them much except a really long, arduous recovery. So here now we'll get into kind of the bane of my existence here. This is a special case. And so an MRI that looks like this, these are what I spend probably 80% of my day going over with people, trying to kind of tell them what's really going on here. So a lot of times when you have an image that looks like this is what the radiologist is going to read. They're going to say there's scattered areas of partial full thickness cartilage loss with complex tearing of the meniscus and subchondral insufficiency fracture. And so everyone's going to see tear, fracture, all this stuff and get terrified. And they're going to come in and see me. I'm going to be like, yeah, you have arthritis in your knee. Because that's what this means. This bone is overloaded with, so fluid is bright on these views. And what we're seeing here is that there's fluid in the bone here. And there's fluid in this bone because it's seeing extra stress, because we've lost the cartilage on the ends of the bones, because our meniscus is torn, and there's no shock absorption capacity here anymore. And so now the bone is seeing a lot more stress. And so again, a lot of times people will come and be like, well, yeah, I'm ready for my scope. I've got tears. I'm like, listen, this is a different animal here. This is showing us that there's more wear and tear in your knee than what's going on. And so that leads us into our next talk, which is knee osteoarthritis. And so we kind of touched on this a little bit already, but let's go into it a little bit more in depth. So as far as arthritis, there's two main types, one of which being osteoarthritis, which we kind of touched on, which is the wear and tear arthritis of the knee. The other is either an inflammatory or a rheumatoid arthritis. And so different pathways to kind of get this that ultimately lead to similar symptoms. Now, again, with osteoarthritis, the biggest thing that we're worried about is this articular cartilage, which vast majority of what I see is osteoarthritis. It's pretty rare that I get somebody with rheumatoid arthritis. So the risk factors for somebody, to that articular cartilage are somebody that's, really high impact activity, if their muscles are imbalanced, if they have a large body mass, this cartilage is going to see a lot of extra stress. And then there are other things that do predispose people to arthritis, one of which being gender. Females have a higher predilection towards arthritis than males do. Age as well, as we get older, we earn the right to a little bit of wear and tear of our joints. And so that all comes into play here. What's interesting is that genetics do come into a role as well as race. African Americans have the lowest rate of of osteoarthritis of the knee. I don't know why that is, but that's what the data says. So all that stuff kind of comes into play here, where some of these things that we can't modify, where you can't do anything about some of this stuff, the way you were born, the way you were made, but there are things that we can do. And so typically this is usually somebody's going to come to me, their knees hurt for months, years, they've been dealing with this for a while. It's pretty rare for me to see somebody that has an acute onset of arthritic knee pain. Usually this is like, it's been bugging me for a while. Usually the symptoms are going to be worse in the morning or long periods of sitting. As we kind of touched on earlier, joints that have arthritis are trying to stiffen up. So long periods of immobility while we're sitting there, that's when, it takes a little bit to get our leg underneath us, get that thing moving again. And so all that stuff will usually aggravate this. And so same thing in the morning. A lot of times that pain will be worse until we get that joint lubricated because we haven't been moving it all night. And so usually I will hear this a lot too, that the weather can affect this too. Pressure changes in the atmosphere will change, our joints. The other thing too is the cold weather too. A lot of times it makes us stiffen up more. And so all that stuff goes into play here. It's often worse with activity. So the more you're up and on it, and then maybe a little bit better with rest, but usually it's kind of always there for most people. So this is kind of what we look at on an x-ray. This is the difference between a normal knee and an arthritic knee on this x-ray. And so when we look at this normal looking knee here, the first thing I look at is I look at the space on the inside, the outside of the knee. Now cartilage doesn't show up on x-ray. The reason that it looks like there's space here is not because this knee is floating in space, it's because there's cartilage that doesn't show up on x-ray. And so when you look at an x-ray like this, what this tells me is that they have lost all the cartilage in their knee, that now the bones are touching. And so when you hear somebody that has bone-on-bone arthritis, this is what this is. Bones are now touching. There's no cartilage cushion in there anymore. And so a lot of times they're going to be painful along this joint line. They can get some swelling. That's usually activity related depending on what they're doing. And a lot of times it'll be stiff. I have some older patients that come to me with knees that look much worse than this. And it's like, man, that has to kill you. And they're like, it's stiff. They will not tell me that it hurts them. They just say that it's stiff. And so that's one of the things I love about my patients here in Iowa is most people will not complain very much. But again, this definitely does lead to some stiffness, which, again, I think in other people's bodies, that stiffness might be quite significant pain. But so the other thing and that I get into with patients, this right here, it's hurting too bad. It can't just be arthritis. There has to be something more going on in there. I need an MRI. And I'm always happy to order the MRI. I can certainly get that for you, but I can tell you it will change nothing about the way that we treat this because your x-rays tell us enough. There's one surgery that will make this knee better, which is a knee replacement. So when we look at these radiographic hallmarks of arthritis here, this is kind of what we look for. Now, the first and foremost thing that happens is this joint space narrowing. The space between these decreases because we're losing that cartilage layer that usually is there. So as that does decrease, then your body does these other things to help protect this knee. So the next thing that it does is that we lose the cartilage here. Some of the joint fluid leaks into the bone here, and you get these little cysts that form in there. And then the other thing that happens is your body starts to form these bone spurs. People think of arthritis as being synonymous with bone spurs, where it's like, I have arthritis, I have bone spurs. Bone spurs are really more of a symptom of the arthritis. They're your body's attempt to try and stop this joint from moving. It recognizes every time this knee moves, it hurts. I don't want it to move. So it's trying to form these bone spurs to basically bridge across your joint to stop it from moving. So one of the questions I get asked is, well, why can't you go in there with the scope and grind down those bone spurs and all that? Because I've done nothing to restore the cartilage. They will come back. And so that's why, again, a lot of times people want a clean out type procedure. It doesn't work. It's about as effective as an injection. So treatment, again, non-operative is the mainstay. The worst thing I do to people is knee replacements. It is the most painful surgery I do to people, the hardest recovery. So any of you that have had that discussion know that I told you probably for a while you're not ready for this yet. And so, again, usually a few different things have been shown by our AAOS, which is our governing body, to be effective here. One of which is either supervised home exercise program or PT. Again, that helps with some of the stiffness. And the other thing, too, arthritis gets worse over time. It doesn't get better. So maybe it's not surgical now. High likelihood, if you're staying active, that at some point you may need something in the future. Number one determinant of range of motion after a knee replacement, afterwards is what it is beforehand. And so sometimes the therapy just helps condition your muscles, helps you have better range of motion. And so that way, if it ever comes to surgery, your outcome will likely be better. So again, activity modifications, we talk about limiting impact. Again, I don't take many activities away from people, but if you're a runner, you like to get on the treadmill, I probably will tell you maybe don't do that. Get on a bike where you're not impacting that knee as much, or an elliptical or a new step, something like that where we're limiting the impact, because that impact does affect this articular cartilage. So anti-inflammatories, which again, in this patient population, I use very sparingly because they have all sorts of side effects, but I do use quite a bit in injections. Now my go-to is cortisone or steroids. And so the cortisone is a Band-Aid. It is basically, the steroids, what they are is they're the most potent anti-inflammatories that we have. So it goes a long way to help pain and inflammation in the knee. Doesn't regrow the cartilage, doesn't cure anything, but at the same time, a lot of people notice good pain relief, allows them to stay active, do the things that they want to, and helps them avoid a knee replacement. So that's usually my go-to. Now the other injections, and the one that a lot of people do ask me about, is this stuff, this gel injection. It has all sorts of different names. Some people have maybe heard it as like the rooster comb, which is where they get it. They get it from the comb with these roosters. They spin it down and they get this protein. Basically, it's hyaluronic acid, which is one of the main components of our normal joint fluid. And then you inject it into the knee here. Now, there's these places in Des Moines that have these real fancy cartoons that do this. And it's like, look, it's opening up your knee joint. Look at all that space. It's cushioning it. Doesn't do that. I always tell people that if I were to stick this in your knee and go send you to get another x-ray, it's going to look the exact same. It doesn't really open up your knee joint. What it does is it's supposed to help lubricate the knee. Again, it's kind of the normal component of your normal joint fluid. And then this stuff doesn't work for everyone. I always tell people coin flips odds whether it works for you or not, which is part of what I don't love about it. But I think the difference is in the people that it works for, the other thing that this is supposed to do is that synovial lining, that knee joint lining that creates our joint fluid. When you have arthritis in there, your body recognizes it's a problem, and it creates all these cells to help fight that, and that's where a lot of the inflammation comes from. So the other thing that this is supposed to do is to stimulate your knee joint lining to create more normal joint fluid, to create a more stable environment. I will tell you, not everyone gets that effect, and so again, these I use somewhat sparingly because they're thicker, more painful injections, if any of you guys have had them. And again, I don't love the unpredictable nature. Most people will get at least some relief from a cortisone injection. The gel stuff sometimes is like we did nothing. But the upside is that if it works for you, sometimes it's a good 6 months of relief as opposed to usually only the 2 to 3 that you get from a cortisone. So it's sometimes worth trying just because I do think if it works for you, it works great. Now the other options are these things like biologics, PRP, stem cells. Basically in these scenarios, you use some way to get your own blood, you harvest it down, spin it down, and then take these special growth factors, inject it into the knee. Now the thing about this is we already talked about, there is nothing that regrows your cartilage. So if there's anybody that wants to take your money for this, because none of this stuff is covered by insurance, when you have bone-on-bone arthritis, do not let them, because it will not help. It will be the data out there says that this stuff for an arthritic knee is as effective as this stuff, which is cheap, covered by insurance, and this is not. So I do very little of this, especially in this scenario, because I'm not a believer that it really helps. I mean, it might give you some relief, but about as effective as a cortisone injection for about $5,000 out of your pocket. So I don't think it's worth that. So they're bracing for these. These are some of the few bracings where I do think is an option, but if you look at this thing, you can imagine how not fun this thing is to get on and how not comfortable. So preferentially, most people, when they have arthritis, it's usually one side of the knee that will wear out more than the other. And so what these braces do, it's called an unloader brace. Basically, they have these little dials that will allow you to kind of crank open that part of the knee to relieve some of the pressure. Now, again, they're big, they're clunky. Sometimes they can be uncomfortable in and of themselves, but these can help some people. So somebody that's really not excited about surgery, this might be an option that we could try, but I will tell you, compliance with these braces is very low. A lot of times people will wear it once, it's like, yeah, no way, that thing stunk. So, all right, so then we get to the big thing here. Now, you've broken me down, you've complained to me enough, you've let me try enough injections, you let me put you in therapy, and we're finally like, all right, let's talk about your knee replacement. So there's really, and again, what we talked about just now about preferentially wearing out one part of the knee versus the other, there are partial replacements of the knee. Now, you have to be a perfect candidate for that to work. And I will tell you, even some of my partners in Des Moines that are very high volume joints guy, they do very little of these. Even if I see somebody that I think is a good candidate for these, I send them to those guys and they come back with this. So I don't really do partial replacements. I don't know that there are many people in Iowa that do them. You have to kind of be the perfect candidate for that, but it is an option. The big thing that I do are total replacements. And so with this, I think some people have it in their mind that we basically lop off the whole bottom of the femur, the top part of the tibia, but it's really, when you look at the side here, it's really the joint surfaces, all those surfaces that have that junky cartilage that get cut off here. And then we put this metal cap on the bone here, a metal cap that sits on the top of the tibia, and then there's a plastic piece. Now the plastic doesn't show up on x-ray, but there's a plastic piece that snaps into here. And then I always use a little plastic piece on the undersurface of the kneecap here. And so, like I said before, this is not an indication for a scope. People ask me all the time, can't you clean it up? It doesn't work. So what does it look like afterwards? So what I think makes the knee replacement a very difficult recovery is that not only do I do this very painful surgery to you, then I immediately tell you, get up, walk on it, bend it, straighten it, move it. Because otherwise knees are notorious for getting very stiff. So knees are unique in all the joint replacements that it's one of those no pain, no gain recoveries where you got to get up, you got to move, because you have about 6 to 8 weeks to get your motion back. And if you don't, it's a big problem. It's stiff. And that's when we talk about taking people back to the OR to manipulate things. It's a big, big problem. And so knee recovery is, at least in my mind, the hardest of all the recoveries of the things that I do to people. But PT is mandatory. I have some people that ask about, can I do exercises on my own, or it doesn't work. Even having home health, somebody come to your house, not as effective as going. They have all the tools, utilities there to help with all that, to get the good therapy. Those people know what they're talking about. And so again, this 6 to 8 weeks is the golden time. And so it is mandatory. You've got to be working with a therapist. Narcotics, the other thing, again, we talked about no one loves the idea of taking opioids. The one thing I tell people, like we just were talking about, therapy is the most important thing here. If you don't do your therapy, this thing will stiffen up and it won't work. And so what I do tell people is if your therapy is suffering because it's hurting you too much, then that means we need to medicate to get that pain under better control, get better therapy. The therapists here in town are all excellent, whether I send people to Total Rehab, to the hospital, Postels, they're all great. They're all really good about telling you too. If they think, you know what, there's more we can do with you, maybe take a pain pill before your next visit and all that stuff. Now again, most people within about 6 to 8 weeks are taking very little of this, but it is important because again, it does help with the therapy. Now, these ice machines, some of you that have had this done know how helpful those are. Basically what they are is it's a little cooler that plugs into the wall and has a pad that straps to your knee. It's really nice because it helps with pain and inflammation of the knee. It's also really nice because you're not having to change out ice bags, and it never gets cold enough to cause any tissue damage. So that helps a lot. We usually use an aspirin or a blood thinner for a month because your mobility's decreased, your risk for blood clots goes up. There's always a lot of swelling for quite some time. I had a lady one time, I did her surgery on Tuesday, and she called me the following Sunday. It was a knee replacement, to say, hey, my knee's still swollen. I'm like, oh, okay. Well, we can expect that for many months to come here. So it's a huge surgery here. And so I do tell people 9 months to a year, really full recovery. Now, about 3 to 4 months, most people are feeling pretty good, back to doing most of their things, but you will get occasional hiccups here and there. And so again, I do think it's probably a full year till you stop thinking about this. It's a lot. So the recovery afterwards, what can you do after a knee replacement? So again, low impact activities are encouraged. We want you up and moving, walking, bicycle, golf, swimming, all that stuff. Now, high impact activities are not the best to do because again, we've got a plastic piece in here that will wear out if we're doing too much. There's also a cement interface that interfaces here that, if you're doing too much there, it can loosen that thing and it's a problem. So usually the high impact stuff we don't want. Now, there's no rule about kneeling after a knee replacement. Now, your incision, as you saw back here, is right down the center of your knee. So some people do find it uncomfortable to kneel on that knee just because their incision's right there. But some people have no problem with it. So there's no rule. It doesn't hurt the implant. Some people just find it too uncomfortable. You may not want to kneel again, which, again, is what it is. The other thing that we do is we do some dental prophylaxis for 2 years. And so if you're having any dental cleaning, any dental work, As any bacteria gets into that blood, the first place it's going to want to go is your knee. And the problem with replaced joints is that bacteria adheres to the metal. And so no amount of antibiotics will ever get rid of it. And so a lot of times if something like that happens, it means more surgery. It means washing things out, cleaning things up. It's a mess. And so usually you take a single dose of antibiotics about a half hour before your appointment, helps protect you for that and just helps me sleep at night. So the other thing that people do complain to me about is this right here, where there's a nerve that runs down the front part of your knee right here and crosses over here. And our incision has to cut through that nerve as it does. And so a lot of people, the front part of their knee right over here on the outside ends up a little numb or even hypersensitive for a little bit. For most people, that will come back, but not always. And so when that's the case, usually I do tell people, like, you may have a little numb patch here, but it will go away with time, or it won't, but it won't really affect your function significantly. So most people, 2 to 3 months, depending on what you're doing for work. If you have a desk job, sometimes it's sooner than that. But if you're doing anything on your feet a lot, it's a good 2 to 3 months before you're going to want to be on your feet all day. So most people, it's about 2 to 3 months before they're back to work. So that's about it for the knee. Should we just table it for now, and then we'll do questions at the very end?
Yeah, I think that makes the most sense. Let's take a little bit of a break. We'll gather back here probably in about 55. How about we do that at 55? Does that sound good? And then we'll resume. So thank you. All right, let's take a break. So as you leave, make sure you pick a variety of different things out. There's been some question. They're not giving away ping pong balls, although that might be good. That's a way to stay active.
Yeah.
But this is actually lip balm. So make sure this lip balm. So pick up something on your way out as we leave. All right. So Dr. Tedesco, let's gather back and let's talk about the shoulder.
All right. Just give you guys another minute to get settled here. So, all right. Well, let's move on and talk about the shoulder, the other thing that I probably see and do the most of. So similar to the knee, let's talk about the anatomy here first. Now, there's 2 major joints that make up our shoulder. First of which is the... There we go. The first of which is the acromioclavicular joint. What that is that's where the top part of our shoulder blade meets our collarbone. That's kind of the bump on top of your shoulder. Almost everyone over the age of 25 develops arthritis in that joint. So if you see an x-ray that says arthritis in your acromioclavicular joint, don't worry about it. It's no problem. This other one right here is the bigger one. The ball and socket joint is called the glenohumeral joint. And that's where, again, the more important joint, that's where a lot of the motion rotation of our shoulder comes from. So like with our knee, we have these static and dynamic stabilizers. So the static are going to be the things that don't move, our ligaments. There's this soft tissue surrounding. So this is a picture from a scope looking at the shoulder. So we have the ball here, here's the socket, and then this soft tissue surrounding is called the labrum. Now you can see the socket is not very deep in most people, and a lot of times it's really quite flat. So this labrum helps to kind of deepen that socket to give you more stability. This up here is your biceps tendon that comes in and inserts at the top part of the socket. And so the biceps can be a big pain generator too as it kind of inserts up and through here. And so there are all sorts of different muscles that attach to our shoulder blade. There's actually 17 different muscles that attach here. And so with shoulders, I think in particular, shoulders are notorious to cause a lot of what's called referred pain, where problem might be here, but you might hurt here, in the back, all over the place. And a lot of that is because when our shoulder starts hurting, we build all these subconscious mechanisms to move it that we don't realize that we're doing, but all those other different muscles start firing differently. And so a lot of times this whole thing will hurt. Then, like with our knee, we have these shock absorbers. Now, with the shoulder, the main shock absorber is our articular cartilage. Now, what's nice about the shoulder is it's not as much of a weight-bearing joint as our knees, as our hips are. We're not putting weight through it when we're up and walking. And so, for most people, it's pretty rare to develop wear and tear arthritis of the ball and socket joint. But we'll talk into things that can lead to that. So let's talk more about this notorious rotator cuff. Well, a lot of you have probably heard about the rotator cuff, know someone that's had surgery for this, or have an idea of what this is. But basically what the rotator cuff muscle is it's these group of muscles that kind of form this cuff of tissue around the ball. And so there's 4 different muscles that make up this, one of which, the one in the front here is called the subscapularis, there's one on top called the supraspinatus, and then there's 2 in the back called the infraspinatus and then teres minor. And they're really important for a lot of the motion and the rotation of the shoulder. And then up on top of that rotator cuff, right in here, there's a fluid-filled sac called a bursa sac. You can imagine your body doesn't love the idea of these bony prominences rubbing on its tendons, and so it kind of lubricates this area with a fluid-filled sac. Now, that fluid-filled sac sometimes can get inflamed and cause problems and cause bursitis in the shoulder. But the primary function of your rotator cuff, which is really why it's very important, is it helps to compress the ball in the socket, to give us basically a fulcrum to lever the arm around. When you have a big tear in your rotator cuff, when you try to raise your arm, it just slides in there because you don't have that compression to be able to kind of pivot around. And so that's the main function of it. It's a very common pain generator. Most people that come to me with a painful shoulder over the age of 50, this is the structure that's involved. It's either inflammation of it, it's partial tearing. It's usually the rotator cuff that's involved. What's interesting about the rotator cuff is that it does wear out with age. About 25% of patients over the age of 50 have tearing of their rotator cuff. They did a study where they got MRIs on asymptomatic people, and a quarter of them over 50 had tearing of their rotator cuff. At 80, 50%. And so it naturally does thin out. And so similar to what we were talking about with those meniscus tears, it doesn't always take a lot to tear a rotator cuff as we get older because that thing is naturally thinning out. So let's talk a little bit more about those tears. Now, again, these can be acute, a big injury, you fell, now I can't lift my arm anymore. Or more often, it's usually just kind of a chronic progressive issue where it's like, it's just been hurting, hurts to lift my arm, I'm having to lift my other arm, my other arm to lift it up. So a lot of times that's usually the story that I'll get. Now, risk factors for this, again, age does kind of lead to wear and tear of all of our joints, but smoking, overhead activities, and I mentioned wear and tear of the ball and socket joint is a little rare, but I see quite a bit of it here, and I think a lot of it is the farming activities, all the overhead throwing of big, heavy objects that leads to some of that. And then also just, again, what we talked about with the knee, genetics, family history always plays a role in this stuff too. And then when we talk about tears, we really can have either a full tear or a partial tear. And the reason why that matters is it does kind of change the healing capacity. And so there's a couple pictures here that I think help to kind of make this a little bit clearer about the difference between the two. So when we have a partial tear, there are 2 sides of the tendon that we can tear on. So if we tear on the side that's closer to the joint here, then this is what's called an articular sided tear. If we tear on the opposite side, so on the upper side up here, this is the bursa side of it, or a bursal sided tear. Now, typically of the partial tears, these ones do worse. So if you're going to have a partial tear, these ones usually do pretty well, and these ones can get better without surgery. Now, these full thickness tears where you basically have a hole in your shoulder, those are the ones that usually will be a big, big problem. And this next slide kind of shows us, as this happens, you get this big tear, this tissue will just eventually start retracting and get back this way. And what happens is now there's a hole in your ball and socket joint. All the fluid that your ball and socket joint's creating is constantly egressing out through here. This tendon never has a chance to get back over here and heal in. And so the only way that these can get better, any of these full thickness tears, is with surgery. There's no way to get that tendon to the bone, get it held there long enough to heal in without surgery. Doesn't always mean that these need surgery, because sometimes people are pretty functional with these tears. But again, these are the ones that I do get a lot more aggressive. If somebody's got a tear that looks like this, they can't raise their arm, they're usually pretty active. I tell them, I'm like, listen, therapy's not going to help here. We need to probably fix this. Because again, we can't get this tendon back to where it belongs without that. So again, a little bit more in depth about what these tears look like. So this is looking at your shoulder from the side. And so here, the most common one is this one on top here, the supraspinatus. That's the one that most commonly tears. And so again, this is normal here on the left, and then on the right, we see now there's a hole in there. And again, this communicates a bone beneath us. And so now all the fluid that leaks through in here, and then again, looking at it from the side, this is kind of what it looks like. This would be a smaller tear. As they get bigger, this will kind of continue to retract and all of that. So typically, what's interesting about rotator cuff tears is like we talked about already, a little bit of the referred pain. And so a lot of times people can hurt all up and down their whole arm. Sometimes people will be grabbing right here. My arm is killing me, and I'm talking about their shoulder. I'm getting x-rays of their shoulder. And they're like, my arm hurts, not my shoulder. I don't know what's wrong with you. And so this is almost always the problem, though. It's up in here in the shoulder, but there's a lot of nerves that talk to each other throughout all these muscles that supply some of the skin in these areas. And so a lot of times you can get pain all up and down that whole arm after a rotator cuff tear. It's very common. Another big finding that I see is weakness, where, again, a lot of times people have to pick up their arm because there's just no strength there. They can't do it. Most often they will have decreased range of motion, and one of the things that I will do in this scenario, if I ask them to raise their arm and they can't, and then I will move it for them, because a lot of times if somebody's got a tear, I can still move it normally. There are other problems in the shoulder, something like a frozen shoulder, where that thing is just stuck and it doesn't matter. You can't move it, I can't move it. And so, that's kind of one of the things I do look for, is if your active range of motion is less than your passive, meaning me moving it, that's a pretty good sign that probably something is going on in there. A lot of times people will complain about this too, popping or cracking in their shoulder. More often than not, what's causing that is that bursa, that fluid-filled sac. As you have these tears, it gets inflamed, and that bursa sac, as it gets inflamed, acts like really thick tissue paper in your shoulder. And so people will get a lot of crunching and all that stuff, and that's usually what's doing it. So typically, again, the diagnosis we usually make based on physical exam. So again, that active versus passive range of motion, like we just talked about, there are different special tests, which, a lot of times if somebody's uncomfortable, they have a rotator cuff tear and I've examined them, usually as I'm done finishing their exam, I say, all right, I'm done torturing you, because usually it hurts. I'm putting their arm into all these positions to confirm where it's hurting and all that. And so it's usually not the best, but a lot of times I do have a pretty good idea of whether or not someone has a tear just based on their range of motion, their strength, all of that. And then, again, the x-rays are often normal, kind of like what we saw with those meniscus tears. Now, one of the special cases that we do see sometimes is something like this bottom x-ray right here. So this is an MRI, which is the gold standard, which shows us this, which kind of shows us a nice picture of what we saw in that cartoon, where this is the tendon, should be attached over here, and you can see how it's torn and pulled back. Now, this picture right here, this is one that I may not even need an MRI on this one, because when we look at this, if you remember, the main function of that rotator cuff is to keep the ball compressed in the socket. And so when I see that ball is not sitting in its socket, it's riding up high, that tells me that you have a very large rotator cuff tear, and you've had a very large rotator cuff tear for a very long time. And what's interesting about these is that sometimes somebody comes to me with an acute injury. Their shoulder never hurt them before. We're doing fine. I was doing everything. I was throwing a ball with my grandkid, and then I fell on it, and now it's killing me. And this is what their x-ray shows. And I'll be like, well, you have a big rotator cuff tear, and it's been torn for a long time. And they're like, well, how? How is that possible? I had no pain a week ago. And it's like your body's ability to compensate is only so good until it can't anymore. And then once you lose those compensation mechanisms, it's just, that's it. Now it hurts. And so when I see an x-ray like this, like I said, more often than not, that rotator cuff is massively torn. It's usually not repairable. And so we'll get more into that, what that means later. So as always, treatment is non-operative for the first line. As you can tell, I'm a super conservative surgeon. We usually can manage most of this stuff without surgery. So again, a lot of that does depend on the age, activity level, and all that. If I have a 50-year-old guy, it's his dominant arm, he can't lift his arm, he's got a big rotator cuff tear, those are ones that I sometimes will be like, listen, I don't think this is going to get any better. I think we need to just do this. So there are certain cases where sometimes it is like, all right, you know what, we just need to do this. But most often, especially if it's a partial tear, depending on age, activity level, sometimes we can get things better without that surgery. Number two worst thing I do to people are these rotator cuff repairs after knee replacements. So again, we have the same tool bag available to us here that we did with all our other stuff. PT, injections, anti-inflammatories, activity modifications. The one thing that people love to do when they have a painful shoulder is this: put themselves in a sling. They'll come to me in a sling because their arm hurts, they don't like lifting it. That is the worst thing you can do possibly, because as we get older, we've already talked about how our joints like to stiffen up. You put yourself in a sling for a couple weeks with a painful shoulder, that thing is not going to move again. It's really a big problem. So if somebody comes to me with a sling, I think they have a rotator cuff tear, unless they have a fracture or something like that, I say you need to ditch that sling, get that thing moving, because a lot of times that's actually making the problem worse. When we do an injection, this is kind of what it looks like. So what I do is I feel the back part of your shoulder blade right here, and then we go right up on top of it. That puts us right in that bursa sac, right on top of that rotator cuff, which usually the back part of the shoulder isn't super sensitive. More often than not with these injections, people are like, oh, you're done? And usually it's not so bad. These don't really hurt all that much, and they can be quite effective. So if all this stuff fails, or if it's a big enough tear and somebody that we think is not going to do well without the surgery, then again, the gold standard, at least in my mind, is to repair this. The way that I do this now, some of you have had prior rotator cuff repairs where you have a big incision on your shoulder. What's interesting about that is that the data says that whether we do this through the scope like this or you have an open incision, the outcomes are about the same. So most often it's like whatever's more comfortable in your hands. And so some surgeons that were trained before the days of the scope, they still do open repairs and people do well. Somebody like me, we've only been scoping. And so, again, I have a much better ability with the scope. And the other thing too, with the scope, they're very small incisions around your shoulder, which patients like. And so this is typically what a rotator cuff repair is going to look like. Similar to the knee, there are, again, small poke holes where we use the camera, little instruments to kind of do this. And this is ultimately kind of what we're trying to achieve. And so this is a good representation of those images that we were seeing where this rotator cuff tissue torn, pulled off the bone here. And so basically what we do is we put plastic anchors that have these sutures attached to them into the bone here, and then we use these devices to pass the suture up through the tendon and then tie it down here. And so now we've got that tendon sealed back to the bone. We've got that really nice and sealed off there. Now, all that's holding your shoulder together until this heals in here are these stitches, which are very strong, but they're not that stout. And so what then comes after this is a very slow and arduous recovery. That rotator cuff, this will heal into that bone at about 1 millimeter a month. And so that's a very, very slow process. Most people, that tendon width is about 10 to 12 millimeters. And so for most people, that thing is healing for those first 10 to 12 months after the surgery. It takes a long time. And so that then brings us to this where, again, you're in a sling, this big, bulky, clunky thing full-time for about 6 weeks. Those first 6 weeks, again, until we have some healing that's starting to occur there, we're putting a lot of trust into just stitches that are holding your shoulder together. So as I said, this is the number 2 worst recovery behind knee replacements. These hurt. It's uncomfortable. You're stuck in this big clunky sling. Most people will find it more comfortable to sleep in a reclined position. It's hard to lay in bed with this sling. And so usually I get people started in PT early here. There are some surgeons who after they do this, they don't get you started in any of the PT till about 6 weeks. I find that if I tell you to go home and sit in your sling and do nothing for 6 weeks, people will go nuts. And so I get you started pretty early. Now, again, it's very gentle, very, just mostly the therapist moving that arm for you, but it gets you out of the house, gets you a chance to get things moving a little bit. Usually it's not until about 3 months that we're starting to pick it up over our head again, and that's when they start adding some weights and all that. But again, 9 to 12 months full recovery. This takes a long, long time. So not super fun. So let's talk about another kind of crossover case that'll lead us to our next talk. So a couple things, again, sort of the bane of my existence are these labral tears in patients over 50. Now labrum, again, that labrum is very intimately associated with the ball and socket. So a lot of times when a 60-year-old gets an MRI of their shoulder, if it shows tearing of their labrum, it's more representative of degeneration of their shoulder, where that labrum just kind of naturally degenerates with the rest of the tissue. And so again, people love to fixate on big scary words like tears, and so they see that. They're like, well, what about my tear? I'm like, oh, your labrum tear, that's nothing. Don't worry about that. So the other thing that can be a big problem is the biceps. The biceps tendon, again, we saw where it inserts at the top part of the labrum. That area can be a big problem too. And so, again, that's another pain generator. I don't see as much as the rotator cuff, but that's always on my mind too. Now, a lot of times they go hand in hand. Now, this then is the good, big, special one where, again, we saw that x-ray with that head that's riding up. Usually this is what that MRI is going to show us, where when we look at this is looking from the side at our rotator cuff muscles. So the muscles of the rotator cuff are right here, and then right here, and right here. And so you can see, here's the fat that's beneath the skin. This is what fat looks like on this view. And you can see how this muscle has a lot of that fat around it. This is what fatty atrophy of that looks like. Uh-oh, battery died here. I can't point at stuff. That's okay. So that's what fatty atrophy of the shoulder looks like. Does this pull up? No, it's okay. So when we see all that white surrounding around that muscle, it has a different signal than what we're seeing with the other stuff. That's an indication that that is not an acute tear. That's been chronically there. The muscle's already starting to atrophy, and those are the ones that I sometimes am like, I think a repair may have a high rate of failure here. So then the question is, what do we do in those scenarios? What do we do for those people that have chronic, big, irreparable rotator cuff tears? And that leads us into this next talk, which is shoulder osteoarthritis and rotator cuff arthropathy. So that rotator cuff arthropathy is what we were just talking about, where it's basically degeneration of the ball and socket joint because of a rotator cuff tear. So we'll get more into that here in a minute. All right, so when we talk about shoulder arthritis, we can have primary versus secondary arthritis of the shoulder. And so primary is, again, due to that wear and tear of the articular cartilage like we talked about with a knee. And so, again, I do see some of that here. Again, people that do a lot of overhead lifting, you had a prior injury, dislocation of your shoulder, sometimes can lead you to some of that stuff. The secondary type of arthritis of the shoulder usually is going to follow other things, and again, this rotator cuff tears. And so, again, when we look at this bottom x-ray down there, that is what a rotator cuff arthropathy looks like, where we see joint space narrowing, the ball and the socket are touching each other, but it's a different picture than what we're seeing on top. That top picture, again, we're seeing bone-on-bone arthritis, but the ball is well centered in its socket there. You also see that big bone spur on the bottom of the ball up there. That's usually pretty typical for primary arthritis too. So these are both arthritic, but they're different pathways to get there, and sometimes the treatment is different as well. So again, these are going to present similar to a rotator cuff tear. The one thing I didn't talk much about rotator cuff issues is this right here, which is night pain. Almost always, that's usually I think what breaks people down to come to see me with a shoulder issue is when it starts affecting their sleep. Shoulder issues notoriously are problematic at night. And I don't know if it's that your body's fighting it all day and you're just tired and can't fight it anymore at night, or if it's positioning when we're laying flat, but there is something to that. This nighttime pain with shoulders is a thing, and it's no fun. A lot of times overhead lifting, anything over your head's going to bug it. If you have that primary arthritis where it's really bone on bone, a lot of times people will get a ratcheting sensation in their shoulder. It's really grindy, and it's not a pleasant feeling. Sometimes they'll have decreased range of motion, especially external rotation. Awesome, thank you. Especially external rotation, bringing the arm out to the side. A lot of times they're very limited with that. And then a lot of times, especially if they have a rotator cuff tear, they will have some weakness in there. So when I'm doing a physical exam here, I very carefully will evaluate the muscles of the rotator cuff, especially if you have an x-ray that looked like that primary arthritis. If I think your rotator cuff is good, then again, it does change the type of surgery that we perform here. So again, I will check your range of motion, your strength of those rotator cuff muscles. Now, typically I can make most of the diagnosis on x-ray. Again, I see an x-ray that looks like that, the one that we saw back here where that ball, the socket, I don't need an MRI here. This rotator cuff is long gone. The only thing that's going to make this better is a shoulder replacement. So sometimes, again, the x-rays show us enough. Now, again, if I'm a little concerned about the rotator cuff at all, then I do get an MRI because that really helps us to see that. And so sometimes I will get an MRI if I really want to see what that rotator cuff looks like. The other thing I always get on all of these, especially when we're talking about surgery, is I get a CAT scan of the shoulder. The CAT scan, we haven't really talked much about what that does, but to me, the CAT scan gives me the best three-dimensional bony anatomy. And so most people, their socket is very small. It's about the size of a quarter. And so I like to kind of know what I'm getting into. If I'm going to be putting an implant in that very small bone, I like to know what it's going to look like. And so what I do is I get a CAT scan of everyone's shoulder. I have a templating software that I use that allows me to upload that CAT scan, see what is going to happen with those implants and all that. And so it allows me to kind of prepare far ahead of time. So usually, again, this is what we'll see on the CAT scan, where I can really get a good look at that socket. We have this good three-dimensional anatomy here, so we can kind of see what's happening. I bet you can guess where we start with treatment, which is non-operative treatment. Injections, therapy, all that other good stuff like we talked about, modifying your activities, trying to limit the overhead lifting. This is one of the few problems, especially somebody with a grindy arthritic shoulder. It's one of the few problems that I actually don't think physical therapy is very helpful. It's actually probably the only one where I put people in therapy for this. The therapists make their shoulders grind. It just hurts them. They leave in more pain than they are. So a lot of times unless somebody's really wanting to try it, I usually don't put people in PT here. I don't think it helps all that much, which is very different from most other things. And so what's interesting about the shoulder is that some of those options that we had for the knee are not available for the shoulder. So the gel is not an option. Biologics, again, are still potentially an option, but again, my go-to are the steroids, and then we have NSAIDs if you're able. Now, the operative treatment, there's two different ways to kind of skin that cat, which again gets into a lot of that rotator cuff stuff we were just talking about. So when we talk about shoulder replacements, there's two different ways to do that. One of which is with an anatomic replacement. With an anatomic replacement, we mimic your normal anatomy. So we replace the ball with a metal ball. You get a plastic socket that resurfaces your socket, and this is your new shoulder. There's a few things that have to be intact that we'll get into on the next slide here in order for this to work. And so the other option that we have, if somebody either A, doesn't have a rotator cuff or other issues, is this right here. This is what's called a reverse shoulder replacement. And it's called that because we've done exactly that. We've reversed the anatomy of your shoulder. You now have a big metal ball on the socket side, and you have a socketed implant on the ball side. What that does is it moves the center of rotation of your shoulder, puts extra tension on some of your other muscles around your shoulder that are still working, basically bypasses your rotator cuff. We don't need that rotator cuff anymore with this. So this has been a revelation because traditionally, 20 years ago, somebody had a massive irreparable rotator cuff tear. It's like, well, this is what you got. Nothing we can do. Whereas now this is a very life-changing operation. So when we talk about primary arthritis, again, the indications for an anatomic shoulder joint are arthritis that's limiting function, hasn't responded to that conservative treatment that we've tried. In order for this to work, and again, this is where that CAT scan comes into play. This is where all that templating upfront work on my end comes from. You have to have two different things, one of which is your rotator cuff has to be intact and working. This will not work without that. The other thing you have to have is a good amount of bone stock on the socket side. And so this next slide shows us what can happen in some people. As we start to develop wear and tear of the shoulder, the socket becomes more and more worn, particularly in the back. And you can see how this person started to develop a second new socket here. And so sometimes as this bone wears and wears away, it becomes more predictable and a little bit better fixation to do a reverse on these people because we get better fixation here. There's a big metal implant with all these screws as opposed to that little plastic thing. And so again, sometimes this is a reason why I do a reverse, even if somebody has an intact rotator cuff. So this is what that templating software looks like. So again, I take your CAT scan, I put it in the software. It allows me to move around these implants, have a good view of what I'm going to be looking at. And it's a tremendous tool. This company, they make a targeting guide that's based off of all of the stuff that we template here that I can stick on your socket and then put my pin in there, and it'll put this pin exactly where I've templated it. And then everything works off of that pin. And so this software is very, very helpful. I template all of mine, even the ones that I think are straightforward. Everyone gets a CAT scan because I think that this is very crucial. And like I said, in a lot of people, this looks a lot bigger than it is. It's about this big. So you miss that spot, and then the whole thing is hosed. So we do a lot of prep work up front with these. So the reverse shoulder, again, rotator cuff arthropathy is the main reason that we do this, but other times severe arthritis, again, with that inadequate bone stock. If we feel that we can't trust the socket side, you can see how much better fixation into the socket we get here. We have all these big screws, this big post in there. And the reason why we don't get all that fixation with a normal shoulder replacement is because putting that much material into the shoulder stretches out that rotator cuff, and then that rotator cuff fails, and then it doesn't work. So the other reason why sometimes we do this is for fractures. Sometimes if people break this part of the bone, a reverse shoulder is actually the best way to recover from that. So again, similar with the other stuff, we use a fair amount of pain medication. Now shoulders, I do think, are not nearly as difficult as the knees as far as recovery. For a lot of these, depending on whether we did an anatomic or a reverse, it's only 3 to 6 weeks in the sling, but during that time, you're not doing much. Versus the knee, they're immediately making you bend it, straighten it. Versus the shoulder, it's like, all right, just sit in your sling, let things heal. I do think it's a little bit easier recovery. I think it's a little less painful for people. And so again, that sling for an anatomic, and to get at your shoulder, one of the reasons why you spend longer in the sling for this one, to get at your shoulder, there's that rotator cuff muscle in the front of your shoulder that I have to peel off to be able to get at the ball to do the surgery. Then at the end, we reattach that. But if that thing doesn't heal, the whole implant will not work. And so that's why we take it slow. We basically treat it like it's a rotator cuff repair because we need that rotator cuff. And so a lot longer in the sling for an anatomic. The strengthening usually starts at about 3 months for an anatomic, a little sooner than that for a reverse, about 2 months. Number 1 through 9 out of 10 reasons to do shoulder replacement is this. This is the thing that is most predictable, pain relief. Very quickly, people are like, oh, that grindy, horrible arthritic sensation in my shoulder is gone. It feels so much better. And so a lot of times, again, they pretty quickly will feel a lot better. And so usually you can expect, no matter what, most people when they come with a shoulder that looks like this, you ask them to raise their arm, this is what they have. So more often than not, your range of motion is going to be significantly better. It's going to be better with an anatomic than it is a reverse. We're mimicking your normal anatomy. It's going to work and feel more like your normal shoulder. So with an anatomic, most people can get full range of motion. With a reverse, most people can get up to at least about here, be able to do your hair, brush your teeth, stuff like that. And reach out to the side. The biggest question mark with a reverse is reaching back behind you. I can't predict it. I have one lady that can get all the way up here. I don't know how or why she can do that. Most people end up about here. Now, a lot of times before we get to this surgery, when I tell that to people, I ask them to reach behind them, and they can't do it anyways, and so they're not really losing much. But those are some of the scenarios where if somebody's got a big rotator cuff tear and the only surgery available to them is a reverse, and if their range of motion is very good, sometimes I try to say, you know what, maybe we should do some injections, stuff like that, because you may lose some of this range of motion. You may not be happy about it, even though it might hurt you less. So that's basically the spiel about that. And so afterwards, golf, tennis, even pickleball, 5 to 6 months. Heavy lifting, I try to tell people to avoid. Now, the one thing that's become clear to me as I've been here for 5 years and done this, people are going to do whatever they want and whatever feels good. And so, again, these are guidelines, but it's just how it goes. And then same thing with the knees there, that we do that dental prophylaxis for about 2 years. And so that's about it, I think, for those. And so now I think we have about 10 minutes or so for some questions here.
If you're over 80 and you're sure you have rotator cuff tear, is it good to try to stretch those muscles, like reaching behind?
Yeah, absolutely. I mean, very little, especially once we reach this stage in life. If you've got tearing your rotator cuff, you've got arthritis, very little is going to cause more damage to you. And so trying to keep what motion you do have, keep what strength you do have, I do think does help. And so I usually do tell people, I mean, if you're doing something that hurts and it's like, man, every time I do that, I'm in pain for days, maybe don't do that. But, if gentle stretching doesn't hurt and it helps keep that thing limber, I think that's great.
I don't understand the references to dental prophylaxis.
So basically what that means is antibiotics before any dental work. Yeah, and so for 2 years after most joints, every surgeon's a little different. Some people do it for 5 years. Some people only do it for a year. Most of us do it at least for some period of time. And so basically what it is anytime they're going to be working on your mouth, even cleaning, our mouth is a cesspool of bacteria. And so even some of that cleaning, if you get some bleeding of your gums or something like that, if any of that bacteria gets in your bloodstream, it wants to go right to your replaced joint. And so typically, again, that you take whatever it is, usually it's a penicillin derivative is what I use, but if you're allergic, then we have other options that you take about a half hour beforehand. And again, it helps to kind of mitigate that risk. I don't know that it really actually does, but it helps most of us sleep at night to know that we're kind of doing something to help and prevent that. Because an infection in a replaced joint, we didn't get too much into complications because I didn't want to scare anyone away, but it can be disastrous. And so, again, a little something like that might maybe help, and I think it's worthwhile.
I guess I'm next. What's the relationship between inflammation and the development of osteoarthritis?
So usually, and most of the time, now again, if you have a rheumatoid arthritis, it's usually the inflammation that's going to cause the joint destruction, where it's actually in people that have rheumatoid arthritis, that synovial lining basically attacks the articular cartilage. And so it's actually the inflammation in that scenario that's leading to further damage of your knee. Yeah, so with wear and tear arthritis, it's usually that the knee starts to become arthritic first, and that your body then recognizes this thing isn't moving right. It doesn't feel right. It's hurting me. And so then again, that's where it stimulates your knee joint lining to create some cells to fight what's going on in there. And that's where a lot of the inflammation does come from. And so I do think, again, they kind of go hand in hand because the arthritis is causing the inflammation, but typically it's usually the arthritis, or it's the inflammation that is causing you the pain, the swelling, all that stuff. But the inflammation is usually your body's response to the arthritis, if that makes sense. Sure. Yeah. So a frozen shoulder is a very unique, and one of the reasons I didn't get into it is because it's one of those problems that no one understands very well. People sometimes get a frozen shoulder for no reason whatsoever. Sometimes it can follow trauma. Sometimes it's because they have diabetes, other problems. But basically what happens in a frozen shoulder is that the lining of the shoulder joint, the capsule, gets very, very inflamed and frozen. The other name for a frozen shoulder is called adhesive capsulitis. So basically stuck inflammation of the capsule of your shoulder joint. And so, again, sometimes I see these people that have had no trauma to their shoulder, no problems whatsoever, but they can't move the thing. And it's like, I don't know why you have a frozen shoulder. And so sometimes, again, there are reasons that people have developed it, whether they have underlying risk factors, but it is a strange and unusual pathology. What's very interesting about it is for most people, they'll wake up one day and it's gone. Just like, I don't know why that is. It's very rare that I operate on a frozen shoulder. I usually make people live with it for about a year at least, because most of the time it will work itself out within that first year. But again, it's a very not well understood problem of the shoulder, but it's ultimately an inflammatory condition of the capsule that can follow all sorts of different reasons. Yeah.
Is there any research on artificial meniscus?
There is. It's not great. Yeah, because they've also done meniscus transplants where you take cadaveric meniscus and transplant it in there, and then again they've tried all sorts of artificial meniscus. Those things don't really work because there's no great way to anchor an artificial plastic meniscus or something. With the meniscus transplants, I mean it's a big incision, all that stuff, but the data out there, it's just they don't work all that well. But you have a 30-year-old with a huge tear in their meniscus, or they have lost all their meniscus, that is something that maybe you would try to buy them some time, because again, I try to get everyone to at least 50 to 55 before we start talking about joint replacements. And so somebody that's that age that has no meniscus, it's going to be tough to get them there. And so that would be something that we'd think about, but the outcomes are not great.
This is a very naive question. It doesn't seem to me intuitively obvious that metal is the ideal replacement for a joint part. Has there been any research on other substances?
So one of the things that they've used are ceramics that have a little bit better wear properties, especially in the hips. A lot of the heads that they put on hips now are a ceramic material, which have a little bit better wear properties than the metal. All I can say is I know that there are very smart engineers out there that have tried all sorts of different things, and that, because not only are we talking about, is this going to work for, wear of the joint itself, but how does this interface with the bone? Because sometimes, if you put a really rigid object that doesn't give like our normal bone does, then the bone gets shielded from its normal stresses that it's seeing, and then the bone decides I'm not needed here. The bone starts to just wear away. And so, again, all I can say is that there's very smart people that some of them aren't even orthopedic surgeons, but are engineers that have tried all sorts of different stuff. But again, they've everything else that we've tried has not been as reliable. If probably a little longer, about 10 years ago, everyone was getting excited about the metal on metal hips, and now no one does metal on metal hips, and there's all these lawsuits about them because sometimes we try things and it's like, this sounds great, and then this doesn't work that well. So. Again, I'm sure other things have been tried, have had probably catastrophic failures, and we stick with what works. But that's a very good question.
Is there any dietary connection with joint health?
There is. In general, I mean, inflammation in particular has been tied to a lot of diet. I mean, you can Google an anti-inflammatory diet, and it will tell you, things that you should eat that are, anti-inflammatory, and certain things that are pro-inflammatory. One of the notorious ones is sugar. Sugar leads to a lot of inflammation throughout our body, and so, again, limiting that type of stuff sometimes helps with our joint pains, things like that. And so, again, is it going to cure? No, but, when we talk about these things, and we're looking for little ways here and there to take some of the edge off and then make it more livable. And so, again, sometimes that stuff can help. The other, thing that people do ask about is turmeric, which is a supplement, which has also been shown to have some anti-inflammatory properties. Of all the supplements and stuff that people use, that's the one I think that has the best science. People use the osteobiflex, glucosamine chondroitin. Data out there says it doesn't work so well. What I always tell people is if you take something and you feel better, even if it's helping up here, it's helpful. So, again, if it works, it works. Yeah.
In your presentation about shoulders, you talked about a software that you use to prepare for the day of surgery.
Yeah.
Do you use it in the surgery, and if so, how?
So one of the things that's eye-opening and that most people don't know about orthopedic surgery, especially when we're putting implants in people, there is always somebody else in the room, which is a representative of that company that makes that implant. They have all the implants in there. They have all the options. They know the product very well and can help you through it. And so usually, again, that I look at it the morning of, have a good idea, but then those guys, they will have a printout, basically. Once our final templating is done, they'll print off a PDF printout that'll have all the information, all that stuff, and so they'll print that off, and then basically, as I mentioned, that guide that allows me to kind of put where it is, it has these different feet that sit along certain spots of the socket. And so a lot of times the rep will be right there holding that picture up there with, where those feet need to sit. And I'm looking at it right here. I put those feet right where they want. So there is, definitely some use of that intraoperatively. Some of the companies, which is wild, I've never seen this, but some of them actually have an augmented reality where you wear these special glasses and now you can see your plan through the glasses, which is kind of crazy to me. And so,
I wondered if that's what was maybe the future, but
I think it probably is. Yeah.
Very cool.
Yeah.
Okay, so you've showed us a lot of really, I'm glad my son's not here who hates needles, because I think some of the photos, it wouldn't have made it. But so you showed us a lot of really great and wonderful information. This was awesome, absolutely awesome. Did you have at the start, so how do they get a hold of you?
That's a good question. So my office does not require a referral. So you can just call, make an appointment. And so, again, I don't know if we have any of my rack cards here that'll have my office number and all that stuff here, but basically you can just call, make an appointment. Now, we're pretty busy, so sometimes it's a couple weeks before we can get you in and get you seen. But, again, a lot of people, they can just call and make an appointment. So not that hard to get in to see me.
Yes, I do think on the website, right, there'll be information about that.
Sure.
And I guess too, you can always reach out to me if you need help finding that information as well. So,
and like I mentioned earlier, I don't do everything, but I have a pretty good background in most things. So even if it's not something that I do, if it's a hip or something or a back issue, I certainly am a good place to start, because we can at least start getting the X-rays ordered, get you in the right hands, and kind of decide. Because I do see a lot of people for what they describe as hip pain, and they think they need a hip replacement. And then we look at their X-rays; their hip is totally normal. It's not their hip; it's their back that's causing them problems and stuff like that. And so, again, sometimes that can be helpful too, just to kind of know exactly the source of your pain and stuff. And so, again, I see all comers. It may not be your guy to do the surgery, but we'll get you in the right hands of somebody who will.
Awesome. Can you please? Oh, sorry. Yes, go ahead.
Some items to pick up outside.
Yeah. So don't forget the lip balm and Band-Aids and pill holders and a bunch of other really fun stuff. But will you help me thank Dr. Tedesco for being here today? Thank you. All right. Well, this is it for a little bit. We'll see you again in September. Again, please reach out if you have any ideas or thoughts as to speakers for the next academic year. But we'll resume in September. Have a wonderful summer. Turn your phones back on, please. And if you have time to put the chairs away, that'd be great. Thank you so much. Take care.